Welcome to our live webcast, Nerve Blocks for TKA Beyond the Adductor Canal. Thank you for joining us. My name is Heidi Border and I'm Senior Meeting Planner for ASRA and will be the host for tonight's webinar. We are joined tonight by our moderator, Dr. Uma Shastri of the Northside Hospital in Atlanta, who is going to introduce tonight's topic and speakers. Welcome, Dr. Shastri.
Thank you, Heidi, and thank you to ASRA and Pajunk for making this webinar possible. Good evening, everyone, and thank you for joining us for our discussion on nerve blocks for total knee arthroplasty. Seeing the evolution of the management of the total knee arthroplasty patient has really been incredible. We've gone from admitted, uncomfortable patients on PCA to doing femoral and sciatic catheters in patients, still keeping them admitted, but comfortable at least, to doing a variety of techniques that allows us to discharge these patients home in a matter of hours. It really is amazing. And although we've come a long way in finding that sweet spot of great analgesia and early ambulation and discharge, when it comes to regional anesthesia, there always seems to be a new kid on the block that might make recovery even better for our patients. This innovation is really incredible, especially with the aging population, rising costs of healthcare, and personal pressure that patients have to just get back to family and work life. Today, we will be talking about these blocks and the strengths and limitations of the adductor canal, iPACK, and genicular blocks in the management of total knee arthroplasty pain. It is my pleasure to introduce our speaker this evening, Dr. Jeff Gadsden. Dr. Gadsden is an associate professor of anesthesiology at Duke University and chief of orthopedic, plastic, and regional anesthesiology. He has co-authored dozens of peer-reviewed publications, as well as textbook sections and textbooks. He has a passion for teaching and speaks regularly at national and international meetings. He was also my fellowship director and is a mentor and good friend. Following Dr. Gadsden's presentation, we will have a Q&A session. If you do have a question, please utilize the Q&A box at the bottom of the screen. We will compile these throughout the talk for our discussion at the end. On that note, let's get things started. It's without further ado that I welcome Dr. Gadsden.
Well, thank you, Uma. I'm gonna open my screen here. Are you seeing that okay, Uma?
Yeah, that's perfect.
Okay, perfect. Well, thank you very much. And thank you to Pajunk for putting this together and for supporting this. And thank you to ASRA, as always, for prioritizing education and innovative ways to share ideas and education with our membership and with the regional anesthesia community. My topic tonight is going to be about nerve blocks for knee arthroplasty, which is something near and dear to my heart. And you know, a main part of my day job is looking after knee patients. So I hope to share with you some of my ideas and thoughts about how we're doing it and some of our successes and failures and where we've gone right and gone wrong. So to do that, I want to look at the innervation of the knee. And I think this is really, really important in terms of understanding what blocks work well and why. And then discuss a rational approach to blocking the knee in a motor sparing way. These are my disclosures. And we'll start with the idea that total knee arthroplasty really hurts. I mean, it's one of the sort of key procedures that we think about when we talk about the idea of how do you best manage pain in a patient. And as Uma said earlier, we've gone from lengths of stay of 5 days to outpatient total knee arthroplasty. And to me, I think the key pivotal ingredient in how we got from A to B has been in the analgesia. And of course, I'm biased, and I think that, of course, we should use regional anesthesia wherever possible, and it's a really, really big part of that puzzle. For orthopedics, there's no question that regional anesthesia crushes all kinds of outcomes. See, I even talk like an orthopedic anesthesiologist, crush the outcomes. And despite this, despite the fact that we know how well orthopedic patients do with nerve blocks, we have data like this. And granted, this is a few years old now, but if you look at the trend here, it doesn't seem to be going up, at least from 2006 to 2013, meaning that if you're getting a total knee done or a total hip, only 25% of those patients in the US, according to this Premier database study, are getting peripheral nerve blocks. And there are reasons for that. A reason is lack of surgical buy-in, and this is what you get when you Google surgeon temper tantrum on the floor. And we have experienced this, and I think we've all dealt with this at times. And I have my suspicions as to why this crops up now and again. It turns out Google Translate also speaks surgeon. So when they say, I don't want to block, it's really about their own priorities, not related to the patient. And one of the earliest studies I was involved with when I was a trainee in Toronto was looking at orthopedic surgeons' attitudes towards blocks. And we said, hey, if you were undergoing shoulder surgery or an ACL repair, would you recommend a block for those patients? And about a third of them said, yeah, we'd recommend a block for that patient. And then we said, well, if you were getting this procedure yourself, if you're having shoulder surgery or having an ACL repair, would you want to block? And over half of them said, yes, they would. To which I said, yes, I knew it. I knew you were.
Jeff, can I interrupt you for 1 second?
Yeah.
Your color palette is showing on the bottom of the slides. I'm not sure if there's something we can do to.
I will try to fix that. Is that, okay, I gotta share my.
Yeah, I'll let you know when you share.
Is that better?
Perfect.
Okay, all right. Nothing like a box of crayons on the bottom of the screen. And I think another reason why the percentage of patients that receive peripheral nerve blocks for total knees hasn't been 75, 85, 95% is that maybe we're doing the wrong blocks compared to what our outcomes were. And so certainly when I trained, these were the blocks we were doing: femoral nerve catheters, sciatic nerve blocks, sometimes obturator nerve blocks. So they had a dead leg. And it gets to this idea of pain control versus mobility. Yeah, I can make you really, really comfortable, but then you're not going to move. And so where do we strike the balance? And then there's the idea of falls, which also goes with femoral nerve catheters, although the data there is a bit questionable sometimes, but certainly a femoral nerve block does contribute to quads weakness and cause quads weakness. And then finally, we have this. So we're increasingly asking our patients to get out the door. And it's estimated by 2026, which isn't all that far off, over half of all knee replacements in the country will be done on an ambulatory basis. So all this sounds good. How do we get these total knee patients walking comfortably? And I think we need to consider the innervation of the knee. So this is a knee, and on the left-hand side, you've got the posterior aspect, right-hand side is the anterior. So we have the sciatic nerve that comes down the back and splits into tibial and peroneal. And from the peroneal, we get the superior lateral genicular nerve, which winds its way around to the anterior side. We also, from the sciatic nerve, the tibial portion in this case, we get the superior medial genicular nerve, which also comes around from the back. Tibial also gets inferior medial, and then there are some other genicular nerves on the lateral side. We have the inferior lateral genicular nerve and the recurrent peroneal nerve. And we'll talk about these being targets for nerve blocks a little bit later, but we don't tend to block the recurrent peroneal or the inferior lateral nerve because it just gets too close to the common peroneal, which then would give you a foot drop and sort of hamper your recovery efforts. Okay, so that's the contribution from the sciatic nerve. Then we have some branches from the femoral nerve. Saphenous is one, which gives a little twig to the joint capsule on the medial side. we have the nerve to vastus medialis. So all the heads of the vastus muscle, the vasti muscles, contribute an articular branch to the capsule. And this is something I didn't know when I was training or considered when I was thinking about innervation of the knee as a young graduate. So there's a nerve to vastus medialis, and then there's a nerve to vastus intermedius, and then of course the nerve to vastus lateralis. So a bunch of contributions from the femoral. And then on the back of the knee, we have what's called the popliteal plexus. And this is a small, fine meshwork of nerves with dually innervated from the sciatic nerve itself and the tibial, and also some twigs from the obturator. And so together they innervate the back of the capsule, and that's the popliteal plexus. So there you have it. That's it. And I have to admit, it took me a long time to get my head around what exactly was happening here. And but knowing this helps us then plan. And so we can conceive of a set of blocks that take advantage of that innervation. Adductor Canal being one of them, and we'll talk a bit about how that's done. The iPACK, which stands for the inner space between the popliteal artery and the capsule of the knee, and then our genicular nerve blocks, which we'll talk about last. And you can see, by virtue of the fact that these nerve blocks are being done at a distal location in the thigh or around the knee, they are in fact motor sparing. We're not getting the more proximal motor branches that cause patients to get weak and stay in hospital. And I kind of liken this to whole blood versus component therapy. So we started with a bunch of really, really good blocks, femoral, sciatic, the obturator, and they did the entire job. And now we're kind of deconstructing it in reverse, saying, well, if we add a little bit here, a little bit here, a little bit here, and put it together, can we almost reconstruct the effect that we got back in 2005 when I was doing femoral and sciatic blocks for our patients? Well, let's see. So adductor canal block, this has been around almost 10 years. And when I first started to do this, there was a wave of enthusiasm for it. And it seemed like the whole point of this was to do a subsartorial saphenous nerve block. And Uma and I and her co-fellow Kwesi Kofi and some others did a study in New York looking at the effect of a subsartorial saphenous nerve block or adductor canal block on femoral, on quadriceps strength compared to femoral in volunteers. And sure enough, you can see 0 quads weakness. So that was good. We proved that, hey, this block can, at least doesn't give you motor weakness of the quads. And I was still curious though. I didn't quite understand how going from, remember I grew up in the femoral nerve block era. How does a saphenous nerve block, how is it supposed to give you pain control for a total knee arthroplasty? And this is, I did my own saphenous nerve block one day, or Adductor Canal in the OR when I was bored, and mapped out the territory. And you can see that, yeah, it gives you good medial calf coverage, but I still couldn't understand how this could give me good total knee analgesia. And it wasn't until later that I understood that we're also getting or can get the nerve to vastus medialis, which runs very, very close to the saphenous and the femoral artery in the middle of the thigh. And if you look at the innervation, this is a really well-done study, 2 well-done studies out of Toronto, looking at the contribution of the nerve to vastus medialis. On the left-hand side, those green dashes are all nerve to vastus medialis. And then on the right side, that's the olive color, you can see what a contribution it makes to the medial knee. And then if you consider where the surgeons are making their cuts when they're doing a total knee, it's a midline skin incision, patella gets pushed to the side, and then we have an anterior medial smiley face cut on the capsule. So now I get it. Now I get why an adductor canal, it isn't just a saphenous nerve block. There's another nerve involved there, and that nerve is pretty important. Here's the problem. This is a picture that I get not infrequently. And I can see in my adductor canal picture, I've got a femoral artery. I can usually see the vein. I see a white smudge on the lateral side of the artery, and I assume that's my saphenous nerve. I don't see many times the nerve to vastus medialis. And if I ought to get that nerve as part of my block, then where am I going to put my local? In this picture, right in the center, right about there, I see a smudge. And that might be it, or it might not. And that leads to a bit of a dilemma in terms of how to go about blocking this deliberately. Complicating this is the fact that anatomically, most people have what's called a vastoadductor membrane, which separates the saphenous nerve and the artery from this nerve to vastus medialis. And you can see in these cadaver studies, in all 8 dissections, that was the case. That number 1 on the right-hand side, that glistening sheath of fascia, that's the vastoadductor membrane. And so you can see that that would be problematic if you're putting all your local on one side. How does it get to the nerve to vastus medialis? And as we began to do more and more of these, we got pictures like this after our injection, which show there are our 2 nerves. And you can appreciate, hopefully, that there are 2 separate compartments here. And I began to think maybe this is why about 1/3 of my adductor canals are kind of so-so. Some of them are really excellent, and then some of them are fine. Maybe it has to do with the spread of local to that NBM. Here's a video I want to share with you. And so you can see the needle coming in from lateral. It's right at the nerve to vastus medialis. I'm going to sort of go over top of it now. And as I inject the local anesthetic, you can see that nerve really gets highlighted there. You see it's the contrast with the local in the background. Then I advance, click through the vasoadductor membrane, and I put some local beside the artery. And now you see the 2 nerves separately. And most importantly, you can see that they're in 2 separate compartments. We'll do catheters for this block as well. And you can see this is post catheter insertion. We're going to test this catheter in a second. You can see where the 2 nerves are. And if I start the video, you'll be able to appreciate as the local is injected through the catheter, we're getting spread in 2 separate compartments, 2 separate nerves. Again, highlighting the fact that if we were only in one compartment, might we get a substandard block? I started to look back at videos that I'd taken from patients long before I ever thought about the nerve to vastus medialis. Here's one from 6 years ago. And the initial injection to the catheter is well medial of the artery, not good enough. I wanted to get local on the lateral side of the artery to get the saphenous. And what I hadn't even realized then was I was getting both nerves. And there's that vasoadductor membrane. And you can see that right there, 2 different compartments. So we began to, because we couldn't see the nerve all the time, we began to think, okay, well, we'll use nerve stimulation, our good old friend nerve stimulation, and we'll put a hand on the medial thigh near the knee. And as the needle gets close to the smudge or the supposed location of the nerve to vastus medialis, all of a sudden we get a twitch just in the medial head of the vastus. And that alerted us to the fact that, okay, that must be it. And then usually once you put the local in, it surrounds the nerve and you can see, oh yeah, that was the nerve to vastus medialis. And then you can proceed on to the saphenous nerve. And this has worked for us. This is now our go-to technique for finding both of those nerves, nerve to vastus medialis with stimulation, and then you go on to the saphenous. I think it has helped with efficacy. I think that our rate of knee patients on day 1 that say, yeah, my pain is a 5 or a 6 out of 10 has decreased since we started to deliberately seek out these nerves, or the nerve. It also confers, I think, a safety advantage. And here's why. I have heard of reports of patients that have undergone adductor canal blocks and have ended up with not immediate, but eventual vastus medialis atrophy. And I wonder, I have no proof for this, but I wonder if part of the reason is we were not that cognizant of the fact that that nerve is often in the trajectory of our needle as it goes towards the artery. And I know that many of my needle paths have undoubtedly skimmed right by. I hope not gone right through it. But I wonder if those cases were because we're driving the needle very, very close, or in fact in contact with that nerve to vastus medialis. We did a cadaver study that is yet to be published, but here's an image from it where we did adductor canal injections, driving the needle towards the spot that we always thought was relevant, right by the saphenous nerve, and then put wires through the needle, took the needles out, and then dissected it. And in over half of the cases, you can see here the red arrows, those needles either contacted or went through the nerve to vastus medialis, highlighting and reinforcing the fact that, yes, this nerve is in the line of fire and you have to be careful. So I do think it's an important nerve. I think it helps me to understand why this block, which ought not to really do a whole lot if it's just a saphenous nerve block, this is why it works. We're getting that NVM. NVM is in most patients separated by the vasoductor membrane, and nerve stimulation can help you get that NVM and make sure A, you protect it, and B, you get local around it, so your block's going to work as best as it can. Okay, this is what we do. For many of our needs, we're doing Adductor Canal catheters, so we'll feed that catheter in. I'll be careful when I'm adjusting my catheter to make sure that when I inject, I do get local spreading back along the underside of sartorius to get that NVM. And 20 mils seems to be a good bolus, and then we're usually using 8 mils an hour versus a pump. Many of my friends who just do single shot blocks, again, do the same thing. We'll put local around one nerve and then local around the other nerve. So great, we blocked both nerves in the adductor canal, and maybe that's a total solution. And if you read some of the early literature on adductor canal block, you'd be forgiven for thinking that, yeah, that's all you need to do, because some of these studies that compared femoral versus adductor canal suggested it's equivalent for opioid sparing and for pain scores. A finding that didn't make sense to me when I read these studies, and I really couldn't rationalize it, because if you look at this, you're still missing nerve to vastus intermedius and nerve to vastus lateralis. So at best, an adductor canal is half of a femoral block, or thereabouts. And so in an effort to try to at least prove my notion that they're not the same thing, we did a study at Duke where we took patients who had pre-op adductor canal catheters that were well placed, and we made sure that they were working well. We tested the patients, they got a GA. In the recovery room, we tested their block to make sure they had a sensory block of the saphenous nerve. They all did, great. Then they got randomized to get a femoral nerve block on top of that, either with chlorprocaine or with saline. And the thought being that if the femoral block, if they're the same thing, then doing an additional femoral block as a single shot shouldn't make any difference. But if they are different, if the femoral does offer more than an adductor canal, then the chlorprocaine group will experience even more pain control in the following minutes in the PACU. And sure enough, that was the case. So the blue group was the sham group and the red group was chlorprocaine. We chose chlorprocaine because we wanted it to wear off. We wanted the patients to walk pretty quickly, but we just wanted to prove a point that they're not the same thing. And we don't do femoral blocks for our knees routinely. But I was getting kind of tired, I think, of people saying, oh yeah, they work the same. There's lots of reasons why in two different groups of patients in a study that blocks, especially pain studies, will tend to go towards a mean and people will report similar pain scores. So this was an effort to use the same patient to show that it was different. Okay, so let's move on to iPACK. And this is an attempt to get the back of the knee. And here we see a cadaver dissection that we did at Duke, showing this popliteal plexus. And I love how it matches this image from a 1982 sports medicine article. But you see that nerve come off the tibial nerve and all those fine little branches supplying the capsule behind the knee. There are different ways to try to get this. This is my preferred way. So if I image the back of the knee from directly behind the knee, and this is what I'll see on the right-hand side. So I'm seeing femur at the bottom. That's that bright white line. I'll see the artery, and then you can see the two nerves, the tibial and the peroneal nerves, although those aren't my targets. I'm trying not to get those. What I'm after is this fine meshwork of articular branches that lives in here. And so all I have to do is put a needle in between the artery and the bone and get that. I like to use 0.2% ropivacaine 20 mils is a good volume. This is not the block that hurts. This is not the part of the knee that hurts them the most after knee surgery. So I don't need to hammer this. Plus, I think there are some reports of higher concentrations, higher volumes, sort of sneaking up to the tibial or peroneal nerves and giving some degree of motor block. So this is the iPACK. I like to do this in the lateral position. So I'll have the patient sitting for the spinal, then I'll tip them over for their iPACK. This is the first block I'll do. Put the probe behind the knee. Ergonomics are really easy. You see the needle going in from the lateral aspect. And this is what it looks like. So I'll go down and see the condyles of the femur, and then I'll come back up a bit till I have femur and artery. Here comes my needle from the lateral side. Although you could come from the medial. I have colleagues that do it in a frog leg position and they can sneak the probe in that way. It doesn't seem to matter in terms of efficacy or safety, as long as that you can see that needle coming from side to side. And then as you pull the needle back, you're depositing that local, and you can see the artery sort of elevate up off the bone, that space. So all those little fine articular fibers get blocked. And then to round things out, we have genicular nerve blocks. And if we go back to our conception of how the knee is innervated, you can see that this is the last remaining piece. So we've gotten the saphenous nerve, the nerve to vastus medialis. We've got all that popliteal plexus behind. What's left? A couple of branches of the femoral nerve, the nerve to vastus intermedius and lateralis, and then these genicular nerves. And as I said, we don't do the inferolateral ones, so those will remain unblocked. But these provide easy targets to improve the pain control after knee surgery. So putting some local right here at the flare of the femur on the medial side at about 2 o'clock or 10 o'clock, depending on your orientation. We'll get the superior medial genicular nerve. Same thing, mirror image on the other side, gets the superior lateral genicular nerve. And then right here in the little recess or bowl of the tibial flare, that gets the inferior medial genicular nerve. Now, while we're here, I will also do the nerve to vastus intermedius, because it conveniently runs right along the bone before innervating the underside of the patella and a lot of the anterior joint capsule. And so because it's on the bone, easy target. I can just put a needle down, hit the bone right at 12 o'clock, and then put some local there. 4 to 5 mils for each of these, and they're really easy to do. So after I've done my iPACK and after I've done my adductor canal, I'll take a linear probe and go boom, 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 and do these 4 nerves. You're going to see that I've outlined them here with the pictures in plane. I've actually since switched to out of plane. It's so much faster and it's really easy. Remember, your endpoint here is bony contact. You don't need to land your needle in a very nuanced fascial sheath between 2 muscles. So you're just driving it down, hit the bone, aspirate, and inject. For most patients, you will see a little corresponding genicular artery right on the bone where the flare starts to happen on the femur or in the middle of that shallow bowl in the tibia. And that's a nice, useful landmark. It tells you that, hey, I'm in the right place. If I don't see it, it's okay. I just put the local in anyway. And these are the 3 sort of images you would see for those 3 genicular nerves. Here's a little video showing the needle has already made contact with the distal femur. This is the vastus muscle / tendon on top. And then you'll see, not quite yet, but when the local goes in, you might see a flickering artery over here to correspond with the genicular artery. So you're aiming for periosteal spread, so just running right along the bone and lifting it up. So easy peasy. In terms of volume, there have been a lot of studies done, to be honest. This is probably, I think, the first one, looking at local anesthetic deposition for acute pain. This is a set of blocks that have been done for years in the chronic pain world for for osteoarthritis and for other painful knee conditions, but it's relatively new to us, acute pain in regional people. So this again came out of Barcelona in Spain, where they did dye studies, and you can see that 4 mils of 1/4% bupivacaine with some dye in it just spreads all over that femur and really does a good job. So we use 5 mils. It seems to do a good job. Now, we kind of wanted to test the effect of this. It seemed to be doing a good job, but you always want to make sure. And so we recently finished a study where we compared 20 patients who got bupivacaine 1/4% genicular blocks, 5 mils each, versus 20 patients who got sham blocks with saline. We looked at their postoperative opioid consumption, and in the first 24 hours, it was there was a 60% reduction in the amount of oxycodone they needed to keep comfortable. In the second 24 hours, it was again 48% reduction. So really meaningful reductions in the amount of opioids these patients needed to stay comfortable just with a simple block. I know it seems like a lot of pokes, but once you get used to it, it can be done in less than 2 minutes. Boom, 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 and then Vastus Intermedius as well. So it's simple. It seems to be effective. This is not peer-reviewed evidence. I'm sharing with you. This has been submitted for publication. So, but it is our data, and hopefully you'll see it soon in print. So this is our recipe that we use for total knees currently. So every patient gets some PO acetaminophen in the pre-op holding area. We'll do a spinal anesthetic. In our spinals, we have some surgeons that are reliably quick, and by quick I mean academic quick, not private practice quick. So less than 90 minutes or 2 hours. And for them, we'll use mepivacaine as our spinal agent. Is usually between 50 and 60 milligrams of mepivacaine, and that gets us about 2 hours. There are surgeons that need a bit longer, or there are revision cases, and for that we'll still use bupivacaine. And the only problem with bupivacaine is that even though you can lower your dose, there does seem to be some effect in some patients that lasts for 5 to 6 hours, and so that has an effect on our straight cath rates and our ability to get PT to see them in the recovery room and so on. So as much as we can, we're pushing for those short-acting spinals. We'll do our iPACK block, as I said, our genicular blocks in the nerve to vastus intermedius, and our adductor canal block. Intra-op, they get a propofol infusion. Everyone gets 10 of dexamethasone unless they're an extremely brittle diabetic. And then ketamine between 20 and 40 milligrams IV and TXA. And then post-op, we've done as much as we can to try to decrease the amount of opioids they're getting afterwards. So fentanyl IV just for rescue in the PACU. After that, it's PRN oxycodone, maximum dose of 10 milligrams. Our order sets used to have dilaudid and up to 15 milligrams of oxycodone at a time, but we're finding, not surprisingly, that those patients, some of those patients that got those would feel a bit dizzy and have some opioid-related adverse effects. Everyone gets a dose of ketorolac in the PACU, and then they go on to have meloxicam and Tylenol for the next 10 days. So in summary, this is a really interesting topic, and the knee innervation is not terribly simple. It's complicated. It has at least 10 separate different nerves from branches coming from 3 different nerves. And so while it gives us a headache sometimes thinking about different ways to block these, if you consider where these are located and have a good approach, I think you can get some really, really excellent pain control. And it is possible to deconstruct these, as I said, and achieve very, very good pain control with these multiple motor sparing nerve blocks. And then lastly, I hope one thing you take home is that our adductor canal anatomy, or at least our understanding of the adductor canal anatomy, has changed and evolved over time. And the adductor canal block that I'm doing today is not the one that I was doing 24 months ago. It's really changed. Our patients are doing better for it. And I sleep a little easier at night knowing that at least I'm trying my hardest to try to protect those nerves as I go in towards that artery. Well, thank you very much for your time. I've deliberately left a good chunk of time for questions. And I'll just, one more thing. The Pajunk has graciously made these posters available to you if you want to have a set of these for your block area. They have all the techniques on them with some tips and anatomy pictures. So if you want these, just send an email to that email address and include your mailing address, and they'll send you some. So thank you very much for your time. Be happy to take some questions.
Thank you, Dr. Gadsden, for that informative, interesting talk and beautiful slides. And as a reminder, if you do have questions, please submit them in the Q&A box at the bottom of the screen. And we'll do our best to get through all the questions, but because of time, we might not be able to. Any unanswered questions can be summarized and posted on the Pajunk website. So the first question, in terms of the nerve to the vastus medialis, can you comment on the most common location? It seems that it ranges quite laterally to quite medially. And then there's a couple parts to that question. That's the first part. Do you always use a nerve stimulator? I'm wondering if I can just do somewhat of a plane block between the sartorius and vastus to get that nerve.
Yeah, great question. We have noticed, now that we're really paying attention to that nerve, that it is quite variable. And there are times when that nerve is right beside saphenous, and you look for it along underneath sartorius and you don't see it. And then when you go to put the local above or close to the artery, the two of them separate a bit and you're like, oh, there it is. Other times it's way, way out. So there is some variability there that comes with patient to patient. I think that in the absence of nerve stimulation, I think if you were to try to carefully hydrodissect along underneath the sartorius and make an effort not to be intramuscular with in the vastus with your needle, that would probably be a fairly safe practice. The trick would be trying to, I think, identify it after your saline or your local had gone in there to make sure, oh, there it is. And then deliberately put, another good bolus around it to make sure you're getting the right effect.
Okay. And can you also comment on the path of the nerve to the vastus medialis as it moves proximally to distally? And if I do my block distal to the mid-thigh, can I not worry about it?
Yes, I think that's a good question too. I think that, all these nerves that originate from the femoral nerve will tend to converge as you get close to the groin crease. And then as you get closer to the knee joint, the nerve to vastus and saphenous tend to follow a very similar trajectory in that they're coming sort of down the middle of the anterior medial part of the thigh and wend their way medially towards the knee joint. So if they're separated by 2 centimeters at mid-thigh, they're probably going to be relatively separated by 2 centimeters, say a third of the way up from the knee joint. That's been my experience in dissecting a number of cadavers and sort of tracking it. We tend to do our blocks right at mid-thigh. And as I said, there does seem to be some variability, but because of that variability, if you did your block a bit lower, I would recommend being a little bit, I do recommend using the nerve stimulator to try to tease it out to see where it is, or at least using some other method to try to figure out where that nerve is.
And the last comment on this topic before I move on to other questions, can you comment, since you're specifically targeting that nerve and it does have a motor component, is there any clinically relevant motor weakness that you've seen in your practice?
Oh yeah, thank you for that question. So, it's difficult to say. If we know that if you look at the studies, even the one that we did in volunteers, Uma and I did, where we compared adductor canal block to femoral, and we said, hey, there's no motor weakness. we were doing it differently. We were doing that injection right beside the artery. So the amount of local, or even in some cases, the separation between artery and the NBM may have prevented that particular nerve from being blocked. Having said that, we've been doing this now for about 2 years, and paying very close attention to the reports that our physical therapists give us in terms of their ability to do gross motor movements, or walking, shifting their weight, doing a, getting up from a chair and pivoting and that sort of thing. And there's no signal that blocking this nerve deliberately gives you substantial, clinically relevant motor weakness. There's no doubt that you're blocking some motor fibers to that head. And in talking to some of the physical therapists and other rehab specialists, it seems that particular part of the quad's mechanism is important in locking the knee. So even though we're doing a quote unquote motor sparing block, we do caution the patients to say, hey, listen, just when you're sitting down on the toilet or getting up from a chair, still use your hands. Make sure you're well supported, and don't try to do it all at once, just in case. So we're cautious, but overall, we haven't seen a big signal of weakness.
Okay, thank you. So the next question is, I work in a busy ambulatory setting, and do you really think it's important to do all 3 blocks, especially if the surgeon's infiltrating? Can I skip the iPACK and Genicular?
Yeah, that's a good question too. So I will say that they're pretty quick to do once you get the hang of things. It's literally, I got to get a video of this so I can show people. But put the probe on, needle goes down. Oh, there's bone. Aspirate, inject. Next, aspirate, inject, and so on. So times 4. I would have said no. You can skip it, because we didn't used to do it until we had the results from our study that showed such a definite decrease in the opioids required to keep them comfortable in those first 48 hours. And so I think that's the value, case you have to make in your own setting, and what makes sense for you is if you're truly pressed for time and you had to pick, you couldn't do all of them, you had to pick them. I definitely do Adductor Canal. And then I would you didn't ask this question, but I'm going to answer it anyway. If I had to pick between geniculars and iPACK, I might pick geniculars, actually, because of the impact on the opioid consumption. The local infiltration is a tricky subject, because there are good infiltrators and there are sloppy infiltrators. And orthopedic surgeons are not traditionally very patient creatures. And so when I've seen friends of mine who are orthopedic surgeons sort of get in there and do this and expect them to have their same results as Uma, who has years of practice doing incredibly precise blocks with ultrasound. I think that the expectation that those will be the same result is challenging. Our surgeons gave it up. So they used to infiltrate, and then we did a sort of a QI thing, and they realized that they couldn't get the same results that we were getting doing Adductor and iPACK. That was before geniculars even. So they just said, well, fine, you guys do it. It'll save us 10 minutes in the operating room, or 5 minutes, or whatever they take. And we've been going on like that ever since. So if you have a good infiltrator, then probably the need for geniculars and iPACK becomes questionable. I agree. If they're not infiltrating, obviously, I think it has a lot of value. And if you have a poor infiltrator, I think that's where you have to make a decision. If you want to talk to them about, hey, maybe we could do this instead of you, or do 1 or 2 of those instead of all 5 or 6.
On Twitter, there was recently a comment that a high volume iPACK can partially cover the geniculars. Do you have any thoughts about that?
Twitter, yeah. See one, do one, tweet one. That's how we do it now. I think that, look, I think there's not a lot of real estate there. If you think about someone's thigh close to their knee joint, there's different ways to skin that cat. And so if you were to put, come down on the bone and put a high volume instead of choosing 3 different spots on the bone, and then some in the iPACK, would that come around to get all the relevant nerves? It certainly could. I know that there are some of my colleagues that work in other places. Sanjay Sinha, for example, in Hartford, does kind of like a ring block of the knee, but in a very, very precise way, and gets great results. So, I don't know. I haven't seen any good either cadaver or clinical evidence of that effect, but it seems to reason that if you put a large enough volume in one part of that thigh, it would spread to other parts. My worry there is that I have seen foot drop with iPACKs. So if you were to put enough local anesthetic in the iPACK, would you get some unintended consequences? And I think that speaks to the beneficial effect, or the nice effect of choosing and sort of smart bombing these little nerves where they come around the femur rather than just dumping it all in one place. But yeah, that's a question that needs to be answered.
Can you comment on adjuvants that we can use to prolong our blocks? And I'm going to take that one step further, because there's also a question about catheters. So I'm sure that'll be one of your topics on prolonging. But if you can comment if you use catheters when you pull them out.
Yeah. So these blocks are great. And of course, the pain that a patient experiences after total knee replacement far exceeds the duration of action of a single injection of ropivacaine, 0.2%. So we're always after ways to try to get more juice out of the squeeze, so to speak, with our blocks. We do make use of catheters in the adductor canal space. We've tried other options like adding dexamethasone or dexmedetomidine or clonidine, but those just don't seem to quite have the same lasting power as a catheter, especially if you have the ability to send the patients home with a large volume infusion pump that can last out to day 4 or day 5. I think that's sort of like best case scenario. However, I fully recognize that not everybody has the infrastructure necessary to send somebody home or follow someone home with a pump. And so if you're looking at single injection blocks, I think that I have heard, I think my next choice would be dexamethasone. I think that's the adjuvant that we have the best data for in terms of prolonging blocks. And certainly if you add a little bit of epinephrine to that, that's sort of casually called supercane where I work. And that's probably going to get you 36 hours plus out of any one of these nerve blocks. The genicular nerve blocks, interestingly, we used 0.25% bupiplane, and that seemed to provide an effect out to 48 hours. So there's something, I think, also about getting good pain control early that confers an advantage further on, even if the local seems to go away. And how can bupivacaine 0.25% last for 48 hours? It doesn't. But that early pain control gives you a bit of an advantage in terms of keeping that pain under control. Our catheters, so we'll send them home either the day of surgery or the next morning, and they get about 5 days total. And then we'll tell the patients to pull them out at home. We'll give a little video and a pamphlet as to how to manage that. There are different kinds of pumps, obviously, that have different infusion regimens and bolus capabilities and intermittent boluses and all that kind of stuff. That's all a topic for another day, I guess. But yeah, I think we do notice that when the infusion pump wears off, they do say, "Oh yeah, no, I noticed that my pain sort of went up a little bit."
In terms of when you're doing the adductor canal block, do you see any need to also do an obturator block?
No, not really. No, I think that I think the branches of the obturator that we're interested in largely we get with the iPACK, such that it is in that popliteal plexus. Back in the old days when we did femoral blocks and sciatic blocks routinely on patients, there'd be the odd patient, I'd say about 5%, that was like, that medial back of the knee pain on that inside part. I can't feel anything else. I can't move my leg, but it's right there. And we do an obturator block and that would knock that out. But that's a small proportion of patients, 1 in 20. And so I probably wouldn't go after that routinely for that reason. I think the branches that are really, really relevant to total knee, you get with that iPACK.
Can you comment on the risk benefits of doing the blocks before or after the spinal? And then separate from that is specifically with the iPACK, are you worried about, like, what do you do to avoid possibility of introducing infection near the surgical site with the block needles?
Yeah, great questions. So with certainly doing a spinal first and then peripheral nerve blocks after that, you've taken away the patient's ability to comment on paresthesias or any abnormal sensations that they might experience with the nerve contact in the needle. I think that's far less relevant with ultrasound, honestly. I think that, in the nerve stimulator days back, I've got enough gray hair that you can tell this is how I grew up in regional anesthesia. And that was much more of a concern for us because you just never really knew where your nerve tip was going to be. Now we have ultrasound and nerve stimulation telling us, and injection pressure monitoring as well that we use to tell us, oh, you know what, our needle tip may not be exactly where we think it is. Let's back it up and try again. So I think that with those kind of technologies helping to protect the patient and protect the nerves, my concern level has dropped to negligible levels. And of course, we're very careful when we do these things. The iPACK, there are two concerns. You brought up the one about infection, and we're well into sort of 2,000 or 3,000 in terms of N numbers for iPACKs, and have not seen a change in our infection rate. We do use sterile gloves, sterile probe cover, chlorhexidine widely all over the knee joint, and then put the probe on, find our spot, and then use a sterile needle tip and everything. So frankly, it surprises me that our surgeons, who are so concerned about infection, perioperative joint infection is a huge problem, look at us doing an iPACK and say that seems reasonable, and they don't give it a second glance. So that seems fine. The other thing that can go wrong with an iPACK, or potential thing that people have brought up once in a while, is hitting the sciatic nerve. And to that, I say, just make sure you have a good view of it. So if you use a curvilinear probe, especially, you can see the whole wide field of view, and you can bring your needle in a trajectory that comes straight across the screen. So not at an angle, but straight across, and take care to avoid that sciatic nerve and not injure it.
In this multimodal regimen, can you comment on any benefit of cryoneurolysis?
So I can't, because I haven't used it, and we haven't used it in our setting. So I wouldn't want to tell you something I didn't know about. So I'll leave that for another day, another person to talk about. It sounds like a kind of a cool idea. I like the idea. Again, the chronic pain folks have been doing neurolysis, either RFA or cryoneurolysis of the genicular nerves for pain conditions, and I think that we're going to see more and more of that in advance of patients coming to surgery. So we may not have to do these genicular nerve blocks all that much longer if they're being knocked out with cold.
Can you comment on your cocktail for bupivacaine and liposomal bupivacaine for adductor and IPACs?
So liposomal bupivacaine is a long-acting encapsulated bupivacaine formulation. It's not indicated for peripheral nerve blocks outside of interscalene. So anything in the lower limb would be an off-label use. Having said that, we have used it in some cases, and to see if we can. We're facing the same pressures as you guys are, who asked a question about time pressure in the busy ambulatory center. A lot of our needs, COVID has been horrible for so many reasons, but a silver lining for us was that it sort of lit a fire under all of us to get these patients out the door much sooner. And so we've been looking recently at changing from a catheter-based system to something that involves liposomal bupivacaine and bupivacaine mixture. So what we've done is a mixture, a 50-50 mixture of 20 of liposomal and 20 of 0.5% bupivacaine, putting 20 of that in the adductor, so 10 and 10 for each of those two nerves in the adductor, and then saving the 5-5-5-5 for those geniculars and nerve vastus intermedius, and then use some other local anesthetic for the iPACK, as I think that's, again, the one that doesn't need the big guns. And we're collecting data on that. We don't have a good handle yet on how it compares to a catheter technique. So, so I can't really comment.
It looks like we're running out of time. Dr. Gadsden, I'll turn things back over to you for any final thoughts.
Yes, well, I think this has been fun. It's one of those topics that I like the nuts and bolts aspect of it. I like talking about these little nuances to these techniques, and it's been a lot of fun trying to work these through with our colleagues and talk about these, how a technique that is almost 10 years old now, and had a mechanism of action that we thought we knew the mechanism of action or where we ought to be putting the local anesthetic. It's interesting to see how this is beginning to shift, and in a job where people who aren't anesthesiologists sort of sometimes ask me, how do you get up and do the same thing every day? This is one of those areas of I think all of our jobs where we get to say, well, actually, it's not the same thing. We're constantly refining and using our anatomical knowledge and knowledge of pharmacodynamics to make things better for these patients, so they can get back to functional recovery as soon as possible. So in any case, thank you very much for your attention. If you have other questions, please reach out through the webinar link, or if you have my Twitter address or my email address, you can hit me up individually. Happy to answer those questions. So, but thank you very much. I want to thank Pajunk again for making this possible, and also Azra for being the overall coordinator of this non-CME series. So thank you very much for your attention. Have a good night, guys.
Thank you again, Dr. Gadsden, for your great talk. And thank you all so much for your attention and participation. We hope you enjoyed this webinar, and we also hope you're walking away with having learned something. Stay well, everyone. And after a year of virtual meetings, we hope to see you all soon in person. Thanks again, and have a good night.